ASS deficiency. We're looking at those that have a good performance status. We've heard a lot about that today, and the importance of patients having good condition. It will be a global study. We've already discussed the protocol with the FDA. The secondary endpoint is going to be overall response rate. And on the basis of this, again, in discussion with the FDA, that we hope to obtain accelerated approval. And they have said that this would be possible, if we do have an acceptable overall response rate with an acceptable duration of response. So we're very hopeful with that. Our phase 3 endpoint has been planned to be progression-free survival, and where we would hopefully obtain regular approval. The U.S. FDA also wants to look at overall survival as well. The protocol has already been submitted to multiple sites in the U.S. We think that the first patient will be treated later in Q1 2017 or later this year. It will probably take 3 years to do the study. Next is the pancreatic cancer study that you heard about earlier today. That we're still discussing the requirement for ASS deficiency. At least in pancreatic cancer, ASS deficiency may not be as important as other cancers. The study could be ASS1 agnostic to start, and then we could perform a statistical analysis at the end of the phase 2 portion on the total population and an ASS1 deficient subset to inform on how to proceed to the phase 3 portion. Again, still in further discussion. Good performance status, a global study. The protocol has not yet been discussed with the FDA. Our phase 2 endpoint will probably be either overall response rate or progression-free survival, with then the phase 3 being either the progression-free survival or overall survival, and the anticipated first patient to be treated at the beginning of next year, and the study to take an anticipated 2.5 years. Next is the study in AML in combination with cytarabine, that there's not going to be a requirement for ASS1 deficiency, as most AML patients are ASS1 deficient. However, ASS status will be assessed and subgroup analysis will be performed. Again, this is only a phase 1/1B study. There will be older patients. Performance status of 0 to 2. It will be performed primarily in the UK and also in the USA at MD Anderson. 2 doses of ADI, take 20, and the standard dose of cytarabine, which is 10 milligrams twice daily for 10 days every 2 weeks. The protocol was just submitted to the US FDA. Our primary endpoint will be safety as for a typical phase 1 study, but of course we will look at overall response rate, overall survival, on treatment, and the dose escalation portion we anticipate taking anywhere from 3 to 12 patients. We plan 10 in the maximum tolerated dose cohort, and anticipate the first patient again at the beginning of next year. You've also heard about our plans for a liver cancer study, and that our plans for this is that it will be first line study. It will be ADI plus FOLFOX versus sorafenib. We're planning for this to have a requirement for ASS1 deficiency, but again, that is all still being discussed. As with the pancreatic study, it's possible it could be ASS agnostic to start with, in other words, taking all comers and then do a subgroup analysis at the end of phase 2 to hopefully inform us on how to proceed to the phase 3 portion. Child-Pugh-A, again, that relates to the underlying liver function. We'll give the global study. We may want to stratify for Asia versus non-Asia. The protocol has not yet been discussed with the FDA. Our phase 2 endpoint, again, will probably be overall response rate, and the phase 3 endpoint, again, probably overall survival. First patient, we anticipate being treated again at the beginning of next year, and the study duration 2.5 years. There's a lot of enthusiasm for treatment with program DEF inhibitors against cancers. That we know from the preclinical data that's been presented here today that ADI-1020 induces PD-L1 on tumor cells. It also has a variety of other capabilities, as has been discussed by Jim. But a tumor cell PD-L1 interacts with the T cell program DEP1 and quote puts the brakes on the immune response. However, if there's an antibody to PD-1 or PD-L1, those quote release the brakes unquote on the immune system, allowing T cells to attack the tumor. These anti-PD-1 and anti-PD-L1 antibodies are now first or second line therapy in a variety of cancers and are more effective in cancers with an elevated PD-L1. Thus, ADI-PEG20 plus an anti-PD-1 or anti-PD-L1 antibody is logical. And can ADI-PEG20 upregulate PD-L1 on tumor cells in humans as it does in tissue culture? We're very hopeful, and that's what we want to look forward to. You want to require tumors to be PD-L1 deficient on enrollment because we like to see if ADI-PEG20 can upregulate PD-L1 and make these inhibitors more effective. We'll use a higher dose of ADI-PEG20, the 36 milligram dose, and this will be assessed along with the anti-PD-1 antibody, either at the time of first ADI-PEG20 dose or after on-study biopsy shows an increased PD-L1. The protocol has not yet been submitted to the US FDA. We're still having some internal discussions on that. Our primary endpoints will certainly be safety, but also probably PD-L1 expression. And our secondary endpoints will probably be ORR, OS, and time on treatment. And we anticipate our first patient to be treated at the beginning of 2017. So again, that we've seen that the combination therapy has shown exciting clinical efficacy in a variety of cancers, in mesothelioma and non-small cell with Pemetrexed platinum, in pancreatic cancer, which is cited in the nab-paclitaxel, and in hepatocellular carcinoma with Volpons. It's shown preclinical efficacy in acute myeloid leukemia, and a phase 1b study is planned. ADI-PEG20 has a variety of positive effects on the immune anti-cancer response, including upregulating PD-L1 on tumor cells, suggesting that ADI-PEG20 could be at least additive with an anti-PD-1 or anti-PD-1 antibody in humans, and a phase 1b study is planned. And lessons learned from ADI-PEG20 monotherapy are being applied to ADI-PEG20 combination trials. And we think that the future of ADI-PEG20 in combination therapy is bright. Thank you again for your interest on this, and we appreciate your enthusiasm as we try to not only build on what we've done before in clinical trials, as has been discussed, but also on some of the exciting preclinical data that's being generated, which are forming the basis for the new clinical trials, which we have to hopefully bring ADI to more patients. Thank you.
Any questions for John? Good job, good job. So we take a quick break. Okay. Seriously, a quick break. So let's get back at 3:05. Okay, so that we can get out of here before the time comes.效果